So good morning, everybody. It's always good to be here. As you probably know, I am Joe Gallagher, the CEO for the now First Nations Health Authority for about 2.5 months now. I'm from the Tla'amin First Nation. I've been working with the health plan since the early days, even just before the First Nations Health Council was started. So I've got a lot of interesting history in terms of this journey and how it's evolved over time. Very excited to hear the comments this morning from the board of directors and the president and Laura in terms of your discussion on just how it changes when we're up here and that we're now moving into a place where we're accountable to ourselves for the work that we do. And I think that's really important. I recall Grand Chief Kelly telling me on one of his visits into the communities, talking to some of the community folks there, and really trying to explain that the difference in this process when we're involved in it the way that we are now is that we know we'll make mistakes, just like government did in the past. But government never apologized for those mistakes and they never fixed them. But we will, because this belongs to us, it belongs to our people and our communities. So I think with that in mind, it makes an exciting backdrop in terms of the way that we want to do our work and moving forward. So this morning, I wanted to provide you with a bit of an update, a little bit more discussion on the transition work that we've been involved with, and then talk a little bit about working with the Health Directors Association. The First Nations Health Authority, now that we have its final form, if you will, in terms of this organization actually being the Health Authority, needs to understand how best to work with the association, that we have that opportunity to look at a number of issues tomorrow and try and implement what we think is the beginning of the new level of dialogue that we should have between us as part of our relationship that we talked about in the bigger partnership between the Council, Health Directors Association, and the Health Authority. So just looking at those three pieces of the agenda, we'll cover those in very, hopefully, specific sections, and I'm going to watch my time because I think I'm good till what time, 10:30, Keith? Yes, so Keith will keep me on time. That'll be good. So just a little bit of understanding that, British Columbia is an interesting place where the transfer policy since its inception in the 80s that BC has the most transferred communities across the country. We also have the most Indian bands as well, but it's good to know that we have really moved ahead in the area of wanting to take control of programs and services. So a strong history of capacity and collaboration, and the health directors are a big part of this. Your leadership across the province has created the situation in which we have on the ground today and the capacity in terms of running all of the mandated health organizations that are out there. The political will that we have in support of the plan is something that's unprecedented in this country, as you know, through the various resolutions, through gathering wisdom, the commitment that our political leaders have had to take on responsibility to transfer the authority of the federal government responsibilities and program and services to our own governance structure and to create this collaboration among the three Health Directors Association, the Council, and the Health Authority. I think that commitment is something that really is important for us to continue to move ahead, and it continues to grow as we go from year to year, and the conversation continues at gathering wisdom. Accreditation, wanted to mention this because this is really important, that I think we all acknowledge that we want to do this work to the best of our abilities. And accreditation gives us something to think about in terms of the standards in which the services that we provide should be offered, and how we run our organizations and how we do our business and how we talk to one another, I think become all part of that. So with this slide, you can see there's a lot of different elements to accreditation. There are a number of health centers and treatment centers that are now accredited in British Columbia, and many more health centers that are involved in the accreditation efforts. The First Nations Health Authority, and I mentioned this at Gathering Wisdom, is exploring accreditation too. So I want to make sure that we have an opportunity to strive to accreditation standards as a program service provider, as a funder to communities, and as in terms of our own internal governance, how we run as an organization. I think the discussion or the signing of the agreements later on this morning also give us a sense of the standard we're trying to set in terms of how we work together as partners. And I think that's all really important because at the end of the day, we're all striving to do the best we can for our peoples. So to talk about the transition update, to give you a sense of what's been happening in the last while since gathering wisdom, and there has been a lot. It's, for me, the work, and we keep using the term drinking out of the fire hose, it continues to be that kind of an exercise. The amount of effort and work and the kinds of things that have to happen. And keep in mind, when I started this work back in 2007, it was just me. And by October of this year or next year, we'll have an organization of about 300 people and needing to run in a provincial capacity across the province in support of all of your organizations on the ground as a partner to each and every individual First Nations person in this province on their health and wellness journey. So it's a big difference from when we started the discussion in the early days. So it definitely is the concept of a lot coming at you in a hurry. So you've seen this diagram at Gathering Wisdom. The Where We Are piece talks about us continuing to move through the transition period, which was a 2-year period set out in the framework agreement that started in October 2011. We're partway through it now. We are making progress. If you recall this diagram at Gathering Wisdom, in the transition phase, we had only at that time achieved probably the first 2, possibly 3 steps. So we have made a bit of progress since then. It's important to recognize that the transition process and the transition plan to implement this process is something that the tripartite partners own and hold together. And you probably are all aware of the events of last week where you probably received a communique on the work of the federal government and their desire to change transfer date. So it really demonstrated to me, you know, the transfer plan that we have belongs to all of us because the health authority, the health council, we can't control those kinds of things in this process. We have to work together, and we've done that now, and we've realigned the efforts. But it's really a transition plan that belongs to the 3 parties, and in particular between First Nations and Health Canada. And so we're now working to I guess, to reestablish what the timeline is based on the work ahead, and that'll be shared with you, I'm hoping, in the December update on the transition work. So progress to date, I'm pretty sure you've all heard about the initial agreements, Health Partnership Accord, Canada Funding Agreement, HR Sub-Agreement, Health Benefits Sub-Agreement, and Health Benefits Service Agreement. And we also, at the Implementation Committee, recognize that because all this work is taking so much time, there has to be an effort to make some improvement to non-insured health benefits today. We continue to hear, and I know you all hear and share the challenges with that program. And so the Implementation Committee, which is the representatives from BC, Canada, and the First Nations Health Council and the First Nations Health Authority, are now looking to create a working committee to try and make improvements. And we asked Jackie McPherson to sit as a representative on that group on behalf of the Health Directors Association. Discussion will happen tomorrow on some of this in terms of what we've heard from you to date and moving forward to look at some of those areas that we might be able to start on. The approach to assets and software and business continuity is a real big deal for us. When Health Canada anticipated the transfer, and we talked about it in the early days, before we got into the nuts and bolts of it, it was amazing that Health Canada didn't even know what their nuts and bolts were. We ended up in a situation of exploring about 70 different systems, and we've mentioned these 70 systems over time. And simple things around what Health Canada has been doing in a more, from a technology perspective, an antiquated approach. With partnerships with Corral, and so you have WordPerfect and Lotus Notes everywhere, isn't really something that the First Nations Health Authority is looking forward to taking on. So we know there's going to be scenarios where we have to bring on some of the programs and software that they use, because all the people that work with communities today need those tools because that's what they're using today to have their engagement with communities. Some of those tools are good, some of those tools aren't so good. But we're going to try and sort through and take the best of what we can and recognize that there may be some we have to take. We'll plug our nose and get on with it and try and find a new solution moving ahead, working with our communities to find a better way to do that. We also know that there are pieces of the Health Canada infrastructure that we can't have at all. It's just not scalable, doesn't make sense for us because we're going to be an independent operation working in British Columbia and no longer national-wide. Also, it's different because our interests are to be accountable to ourselves, to First Nations people and communities. A lot of the tools that Canada's put in place is to reinforce their accountability to Ottawa. And so they look to draw information from communities about their spending and what they get in terms of widgets and gadgets from communities, as opposed to really worrying about the health outcomes and how well these things are actually working for people on the ground. So we have that opportunity to change that. So some of those things we don't want, and we'll have to build replacement systems in place, and a lot of work is going on in that area now. So the business continuity portion to that is that on day one, we won't have all of that built. And so there's going to be a period in time when the First Nations Health Authority needs to be able to be connected into the federal government network. There's a lot of data information and requirement in terms of how they've connected themselves and how they all are able to work together that we need to borrow for a while until we can have a standalone system and to migrate off of all of the people and the programs and resources and data off the federal systems. So that'll take a fair bit of time, but that's what the business continuity concept is about. So remaining agreements to negotiate, so the assets and software, accommodations, contribution agreements, pre and post, transfer, information sharing, records transfer, and capital. So some fairly significant items still yet to be negotiated in sub-agreements that set the parameters in which the transfer will take place in those areas. I mean, you could go into each and every one of these and find a multitude of complexity depending on what it is we're talking about, and trying to figure out the path moving forward on an interim basis is what we're trying to do, so we can allow for the discussion on programs and services transformation, so we can look at how First Nations want to see programs and services delivered in the future, and taking that discussion into account that will probably start before the transition period is finished, but continue long after for 2 or 3 years until we can actually make those transformation activities a reality. We also have other funding agreements to negotiate. These are monies that are not captured in the Canada funding agreement that you see in the framework agreement. The amount in the back is really what's going to be included in the Canada funding agreement. So what we've recognized is that because we're not transferring on April 1, and maybe with the new approach later in the year, between April and whenever things come across, there is a gap in funding that Canada needs to cover. So we call this the bridge financing area. We need to negotiate what those amounts are. The IRS is the program that Health Canada has put in place as part of their legal obligation in terms of the Indian residential school issue. And there's new program monies that are now identified that were not in the 08-09 budget that Health Canada had. So the commitment to continue our access to those funds, as communities are already seeing some of those monies, are things that will be captured in that agreement. So changes to the timeline, and as I mentioned, the happenings, the events of early last week that looked to change the transfer date to October 2013. So a lot had happened in the last week, and a lot of very interesting and tough discussions with the chair and deputy chair from the Health Council, myself, the officers from the board of directors, and the Health Canada chief negotiator and the DG responsible for Tripartite, as well as direct connections to the minister to really get this thing back on track and to ensure that Canada recognize that they cannot be by themselves deciding how things happen. So it was, as I say, quite an interesting week and a great place to be a fly in the wall to see the activities going on in the different, from here to Ottawa and back several times. So there has been a resolution that will ensure a smooth transfer. What the new timeline does do is that the federal approval that we're hoping that would happen in December will now happen in February. And there's reasons for that, because Health Canada, on their side of it, really underestimated what the business continuity model or approach needed to look like for assets and software, for IMIT. Because they underestimated that, they weren't able to conclude the memorandum to Cabinet in a timely fashion. So it created problems for them. there are costs involved for them that they didn't anticipate that they need to provide to ensure the continuity and the success of the First Nations Health Authority. So that was one of the main reasons why the federal approval was pushed back. A lot of concerns around that, because what it does is that it builds a little bit more time on the good side around concluding all the sub-agreements, but it prevents the delay of signing the Canada funding agreement, which is a level of certainty that we all are looking for in terms of ensuring that the package of money that's in the framework agreement will be delivered to First Nations through the First Nations Health Authority. So the way it sits now, all agreements and sub-agreements reviewed as a total package by the board and the Health Council. So we need to do that, and we'll end up looking at the conclusion of all those sub-agreements still to be negotiated, sitting them alongside those agreements that have been initial to date, do a reconciliation of what we think are all the outstanding issues, and try and determine whether the package works as a whole. So there's a lot of interdependencies. For example, when you think about accommodations, accommodations for the most part looks at the office space that Health Canada has that we'll be taking over. We need to understand the number of people we're going to have to know whether or not it's enough office space. So there's also arrangements to take on those spaces perhaps for 2, possibly at the most 3 years. So we have to also look at the impact of that on operational integrity, depending on which buildings are coming up at which time and so on. So the other side to that is, do we have enough money to pay for those leases for the 3 years? So you can kind of see the interdependency of the various sub-agreements if you go across a set of issues you need to deal with. With that being said, the goal would be to sign the package of agreements by the end of February. That's right now what's the target time frame for doing this. So the new phased approach, we're looking at, and we're able to get some pushback to ensure that we could start in July as we had anticipated and we had set and agreed to with everyone before the unilateral decision came out. And so that now is back into play. The Canada funding agreement, based on this timeline, will come into effect on July 2nd. And that's the goal that we have if we can get it signed in February. With that, then the headquarter functions, which we describe as the head, because that's where, from a Health Canada perspective, the supposed strategic thinking happens. We end up in the discussion on that piece coming over, because what we're really getting on that side is the functionality. So the resources for us to build that strategic level capacity and to be able to provide the direction over programs and services into the future. I like to describe the regional functions as the arms and legs. It's the program and service delivery mechanisms that are supporting community health organizations and providing services directly. And so that piece will come over in October, and that will provide a little bit more time for us to ensure we can get all those things correct. So just for your information, the signing of the Canada funding agreement is very significant. And here's a number of issues that I just wanted to share with you so you can kind of get a sense of that. That without the Canada funding agreement in place, knowing that Canada has to know they're going to give us the money, and we have to know we're going to receive the money. So without that, it's very hard to legally address the First Nations community contribution agreements, because no one can really have that conversation till that decision is made, because until then, that obligation is between Health Canada and First Nations communities. The other piece that's critical is the RJOs to FNIHB staff, those folks that are identified to come over, the full-time indeterminate, part-time indeterminate staff, that the First Nations Health Authority can't even consider giving an RJO if we don't have the money to pay salaries. So we need to confirm we have that. So there's no way we can actually give an RJO before the Canada funding agreement is signed, and that we know it's in effect before we actually give the RJO, and that staff are looking to come over. So negotiating new contracts for services and lease arrangements for office space. Again, the same thing. To sign on to commitments that take us into the future, really can't do it till we know the money is going to be secure. So just a summary of the transition process. So we complete the key agreements. There's the endorsement of the individual agreements by the Council and the Health Authority Board of Directors. We do that as they come out of the hopper, if you will. Cabinet and Treasury Board approvals on the individual agreements that are the February timeline that we talked about. And then we have to look at the package as a whole. And once we feel comfortable with them, then the approval will be given to sign the agreements. So as I mentioned, this is what we're getting. On July 2nd, we get the head. That's all that comes across at that point in time.
Is that your head, Joe?
No, it's not my head. That's the federal head. Is that debatable? Here's the other arm and the legs. So that's what happens on the head on July, the arms and legs on October. We add the heart and soul and the color. So we will become a First Nations health organization by then. So the transfer of the strategic level responsibilities, the head, these are the directorates that are in Health Canada and Ottawa. And many of you have had different opportunities to participate in discussions with each of them. What we get from each of those is the resources for what they describe as BC's share. So from a directorate budget perspective, it's roughly a 14–15% calculation. So we get the resource, we don't get any people, we don't get any baggage, we just get the resource, and we start using that to build the strategic level capacity within the First Nations Health Authority to work with communities directly on improving the programs and services in each of these areas. These are the arms and legs, and all of you know these very well, the various capacity and program and service delivery responsibilities from the region, the regional operations. The capacity they have in these areas include staff, resources, tools, and other things that you're all familiar with. And so these are the pieces that come across with us as the FNI pieces. If you recall in my presentation at Gathering Wisdom, I always talk about FNI plus. So at the end of the day, I think all of us recognize that for us simply to take over the federal government strategic level piece, the head and the arms and legs, really doesn't make a difference in terms of the health programs and services and outcomes. And that the real opportunity for us is to take those core pieces and add it to the, as I described, the heart and soul of the organization, which is us as First Nations people, and really go out there and look at what we can do as a health organization with the various provincial partners that we have around us. That the bigger provincial health system becomes a true partner, as you're starting to see in terms of the various regional accords and other things that are out there with First Nations and the provincial health authorities. So when we talk about building the First Nations Health Authority, a lot of our work is always going to be rooted in these areas here. First and foremost, the 7 directives that come from BC First Nations that were approved at Gathering Wisdom 4. Then we look to the shared vision that's been agreed to by the Health Directors Association, the Health Council, and the Health Authority, and the shared values that were given by those 3 organizations working together. So that really forms the foundation for us to move ahead on. And then we talk about a First Nations approach to wellness. And you've seen this before. We shared it the last Gathering Wisdom. And this is really important. This, to me, is how we're trying to articulate the heart and soul of the organization that we talked about. And you see now in the middle it has human being, and advice from our elder, Leonard George, about, this work is really about each and every one of us working to be the best human being we can be, to come to this work and do the best we can for our people. So it really makes sense that we never forget that as partners, as people working in this area. The work of the wellness model, as I mentioned, for the First Nations Health Authority, we need to learn to be the health and wellness partner of each and every individual First Nations person in this province, regardless of where they live. We need to be a champion for health and wellness. The commitments that we put in play have to support our youngest to our oldest, and really an understanding of how fast our population is growing and how young our population is, which I know you all know a lot about, grandchildren and everyone around, right? So we can't forget. We always have to be grounded in those kinds of things that really, let us know who we are as people. And leading edge of systemic change by aligning with the innovation change agenda of the province of British Columbia, that to me is where our big opportunity is going to be. As we develop who we are, our identity becomes more relevant in the mainstream health discussion in the province of British Columbia. And that the model that we are looking at in terms of living well is something that the rest of the province isn't going to be envious of. And I know that they already are excited about the fact that the First Nations working through the Health Authority and our governance structure can lead the discussion from this perspective as opposed to when we go to their meetings and hear about how sick we are. So it's an exciting opportunity for us. The components of the wellness model, the 5 areas that we talk about being a focal point with everything that we do, the nurturing the spirit, the respecting tobacco, being active, eating healthy, maintaining healthy body weight. And you know, it's funny to think about talking about building an organization, and these are important components, because if we're not healthy, we're not going to be able to help anybody. And so it's not only talking about it, it's about living it. And it's interesting because we've done a lot of work now, and you look at the next slide talking about building a First Nations health authority. So we just put all these things together. These 5 areas, the wellness model, equals, you know, our approach to building a uniquely First Nations health authority. So in our work at the Health Authority, we've tried to start some of that already. We've been looking at the wellness model. I've been challenging my organization to try and tell me what they think it means. And so each of the departments in the organization have now just submitted to my office their department health and wellness plans. And so we're looking at ensuring that we have education, we have activities and initiatives, we have tools to help ourselves in each and every one of these areas. And we have to be able to monitor progress on our health and wellness journey. And so it's something that we need to bring to the Health Directors Association, and that we want to work with each and every one of you to bring this to your communities and your health organizations. So it's important that we have some discussion on this moving forward as we get our heads around it, and we do a little bit better on how we want to look at moving this ahead. Now, it's really interesting because for myself, I'm a very stubborn, recovering soccer player that doesn't want to give up, but I have to. And so 3 knee surgeries later, I now have to have a new plan. And some of my new plan just come up with earlier this week with Janine from my office, who's been helping with this, is to run an Ironman once a month. So I get to break it into 4 sections. And so I got to bike, swim, and run. So I did the biking last year. I did the ride from Vancouver to Seattle. But I've got to keep it up so I can do it again to raise more money for cancer research. But I also have to get the running and swimming in. So I started those this week, and it's been pretty good. But I want to keep track of that. Now, Janine is way ahead of me because she's going to do a triathlon a week. So, you know, she's really looking to push herself to run the Ironman that's going to be in Whistler next year. So what we want to be able to do as a staff is look at each and every one of our departments. And a lot of the departments have done very, very good things around eating patterns, you know, joint lunches, supporting one another, walking clubs. So working on those things we're talking about respecting tobacco. So eating healthy, being active, maintaining healthy body weight, and nurturing spirit. So Leonard George, our elder, spends time now with all of us, with each of our departments. And so we're trying to create a balance in that. And I want to be able to develop an organizational policy around that I can share with the health organizations in BC, but also hear from you. If you have some better practices that you want to share with us, please feel free to send them in. And we can compile that for all of us to work on and look at and to really live those things moving forward. So I think that's the exciting part. We get to create the environment in which we're going to do this work. So key transfer activities, again, you know, creating a shared organizational culture is important. The health and wellness piece is foundational to that for me. The bringing in of 200 some odd federal employees to me is a real scary situation around ensuring we end up with the right organizational culture. Because the people are committed to the work, they do good work, they do different kinds of work, but they do it in a way that's not the way that we want to do it, which is why we're taking this over. So the work that we have to do, and we'll have several discussions with them, and lots of discussions with individual staff members, just around how we put closure to the federal culture and introduce them to the culture of a new First Nations health organization. So I've talked about this before, building solid systems and structures. With the organizational development, the IMIT pieces, the assuming the assets. So there's a lot of things that are coming across, from vehicles to property to facilities to equipment. There's money and financial resources. Taking over the programs and services, obviously the big one being the FNHB that we want to evolve into the First Nations Health Benefits Program and all the current programs and services and contribution agreements. So there's a lot to be done in the work moving ahead. When we look at it from a perspective of here's the kind of the drinking from the fire hose and giving some of it to you to get a sense of the magnitude of what's happening. So information management, information technology. We know that we need to address overarching enablers. So a lot of issues around privacy, information sharing, and management security, procurement, contracts, and licensing. So those things are being dealt with in sub-agreements and other kinds of arrangements to ensure that that whole framework is set out so that things can come across in a smooth fashion before transfer date and by transfer date. So there's a number of big areas to work on, like telecommunications, infrastructure, applications, office automation, and assets. So when you go into each of these areas, there's a lot of different things. You can see on the telecommunications side, just a simple who's on the end of the telephone, what are the telephone numbers, BlackBerries and service contracts, the infrastructure around what we need to run this, starting with a network connectivity, which I mentioned we'll first and foremost borrow from the federal government till we have our own. Look at the telehealth and video conferencing capacities. We need a better way to connect with communities so we can do things sometimes in person, sometimes virtually. The server infrastructure is important so it doesn't crash while we're trying to have all these conversations and do our work. The applications in terms of programs, corporate applications, the programs are the tools that folks are using to work with you, or the programs. Corporate applications like HR and financial systems that can talk to one another, and then the mid-tier and operating system are all part of that. And you go on so on and so forth with the different areas. And what you end up with is a very, very complex and challenging environment that we have to create that doesn't currently exist, but we're well on our way of doing that now with the discussions that we've been having with Canada. So the corporate services side, just to give you a summary of the kinds of things that are happening, we talked a bit about capital accommodation, so the office spaces that we're needing to sort out leases and so on. The Health Canada capital plan, which many of you are familiar with. We're trying to have a look at it and understand how we'll approach that moving into the sub-agreement on capital. We need to develop a master space plan because right now we have some offices in Park Royal, and we're kind of scattered on several floors, and then the federal folks have offices in Vancouver and smaller offices in other parts of the province, and so together we have to fit it all together as one organization. So there's a lot of work to be done on sorting out how that's going to look, the footprint. Finance is a big area, obviously, taking on the responsibility for a budget that will be a lot bigger than what we're doing on an annual basis now, where we're closer to the 20 million range. We'll be closer to 400 million by the time the transfer is done. So there's a lot of pieces that have to be put in place. As you know, with any good financial system, you need all of these elements that you see on the slide. Human resources is interesting. We now have the privilege of sitting with 4 federal unions and talking about 6 collective agreements, and trying to figure out what that's going to look like on day one and where it goes in the future. So it'll create a sense of complexity around the organization, where on day one we'll probably be part union, part non-union. I'm sure some of you know what that's like. So we'll be trying to sort through those things moving forward, and our policies that we put in place that we have today for what used to be the Health Society, now the Health Authority, are being re-looked at and examined to ensure we have the policies we need for transfer date. So a lot of things like that happening. Change management activities for Health Canada and the Health Authority staff is key. As I mentioned, we'll have our gatherings with them and have our discussions and try and find a way to put a closure to that federal culture and an introduction into the new culture of our organization. So a lot of work on establishing the hiring, recruitment, and retention mechanisms. I've been doing a lot of work on trying to secure my executive team. The VP layer in the organization, and just in the final stages of it. And once that is done, hopefully within the next week or two, be able to begin working on a communique to all communities to let them know what that team's going to look like. So I'm quite excited about it. I'm quite looking forward to giving some of the fire hose to somebody else. It'll be very good to have some folks in place that will be able to spend and share the leadership responsibility and spend more time on the various issues that are now flowing through my office. So it'll be very, very excited to have those in place, and the full team should be in place. Well, most of it anyway by January. Full team probably take a little bit longer as we have one or two more things to work out, but the bulk of it will be there. Transfer of contribution agreements is an important discussion that is probably in the forefront of all of your minds and how this is going to work. So we are working out a process with Health Canada And again, acknowledging that right now they have that direct relationship with communities, and that's, you know, a responsibility of theirs to do the initial pieces of this work because their agreements are with communities directly. So that needs to happen as part of this. We're working through a process with them now that will be talked about tomorrow when Michael Hilson is here, as we're confirming some of the details on it that he'll share with you, with Yusuf Ali, who will be here to speak on behalf of Health Canada to their part of this. Health benefits being a big issue for all. I'm, you know, knowing that with the importance of the health benefits area and the discussion that I mentioned earlier at the implementation committee level, there's the need to have the work done to try and make improvements today moving forward. What we'll be doing at the day of transfer is that because of the infrastructure that Health Canada uses to run the FNHB program, we'll be looking at implementing a 2-year buyback period. And that way Health Canada will, because we won't have both the resources and the time to put in our own standalone system just yet. And so it will give us an opportunity to actually have the capacity in place to actually learn how to run a benefit program, but also have time to talk with community about how to transform that program when we take it over fully outside of the Health Canada environment. So it creates a space for that, but it also provides a very immediate need. So Health Canada has agreed to continue to deliver certain aspects of it so that the program will run. The staff, people, and the resources will be with the First Nations Health Authority, and we will be looking during buyback to start our discussions with communities and develop strategies to make improvement on the program and services while it's still run by Health Canada, and for what it's going to look like after we run it totally on our own. So a lot of work here, very complex, and well, they make it a lot more complicated than it needs to be probably. But for us to understand the FNHB management accountability framework and the various pieces that they have in place to run the program, including adjudication processes and the software and the contract they have with Express Scripts Canada that does the claims processing and so on and so forth. So there's a lot of details that we're becoming familiar with. But as I mentioned, in terms of the First Nations Health Authority, we've borrowed Rick Kuzik from Health Canada on an interchange, and he's the only dedicated staff person I have in that area. But we are negotiating the agreements, and as I say, we'll be bringing on and planning for more capacity into the new year. So our ability to work in this area will be increased, and Rick will be part of the discussion with you tomorrow to help move this forward. Just a little bit on regional offices. We've been trying to scope this out in terms of what the regional offices would look like, but in particular what they'll do and how they'll function and so on. And so we're getting closer to it. We had some good discussion with some of the council members, with Grand Chief Kelly and Warner Adam, the chair and deputy chair, just about a week or two ago. In some of our discussion, we've tried to create a common understanding, you know, that these offices are to support community engagement planning and service delivery closer to home. It really is, I think, a common understanding that we all have. The engagement and planning capacity needs to support and inform the work of the Health Directors Association, the Health Council, and the Health Authority itself. It's, you know, the regional community engagement piece is critical to the success of this plan moving forward, and our ability to be responsive to that is going to be dependent on creating efficient regional processes and a supporting mechanism through a regional office that makes sense, so that we don't have any confusion. We have effective and equitable amount of engagement across the province, which, as you can imagine, can be challenging because of the geography that we have and the number of communities. So support for the regional tables and relationships with the regional health authorities, the partnership accords that are out there, is a critical function that the regional office needs to serve. There's a lot of, within those last two bullets, there's a lot of requirement in relation to community health and wellness planning, as well as the strategies around how to work with the regional health authorities that have to come together and be informed by one another. And then service delivery staff that may be housed within the regional office. At a minimum, we're going to have capacity in the regional offices that can leverage and link into the service capacity that the health authority has. So we've got to figure out where all those pieces are and what they look like. Not a clear picture yet on where everything is going to sit, as we talked about doing the the overall sort of footprint across the province and what that's going to look like with accommodations and resources. So there's a lot of that needs to be figured out moving forward, but the commitment in the regional office is that there should be discussions there about ensuring that the services that the First Nations Health Authority is supporting or providing within that region, that there's a place there to talk about that and to try and identify gaps or improvements or collaborative initiatives or new developments that could be put in place by us working together. So a lot to be done in that area. So in closing on the transition piece, as I put up at Gathering Wisdom, the same slide, that we look at our 7 directives and our collective values to guide us in our way to move forward, and that until Transfer Day, Health Canada maintains decision-making and service delivery responsibilities over their current areas of responsibility. So a lot of times we get into an interesting discussion when they don't want to make an answer, or they tell everyone they've got to go talk to the CEO, and that's not always the case. So I'm trying to work with Yusuf to make sure we're very clear on how these things are done and that Canada continues to do its work and live up to its responsibilities to community. The Health Authority will continue to implement the Health Actions Agenda to achieve system transformation today. That's an important piece. The table's been set for tripartite collaboration. And keep in mind that those strategy tables are really intended to make space for the decision-making from health directors and the folks that are making decisions on health services at the local and regional or sub-regional levels. That's what those strategies are intended to do. They're not intended to tell you what to do. They're intended to make the space for you at those tables as we evolve the work moving forward. And again, the last piece on the health and wellness model, and that we will continue to develop the role as a wellness partner to each and every health organization and each and every First Nations person across the province. So moving into honoring the voice of the association. This I think is important for us to spend time talking with you about and get right, and to put into practice and try and get feedback on the practice that we think is what's moving ahead. So we're looking at the idea of the governance structure that we have, and everyone's sort of seen this diagram in the consensus paper. You see the three components to it: the political advocacy role of the council, the technical support and the advisory role of the Health Directors Association, and the service delivery functions of the Health Authority. And we recognize that this changes the closer you go into the center, where the center would be right on the ground with communities. So we have a difference in terms of what the kind of functions and responsibilities are at each level. And I think we're all still trying to figure that out. I know in discussions that we have around it, and when we become responsible for all the federal programs and services, our relationship really changes with each and every community. Right now, we are not the funder of communities for the programs and services you deliver through your mandated health organization. We may provide a little bit of something, but we're really not the funder. When we become the funder, our relationship becomes a lot more interesting. It does change a lot. And we have to be able to approach it in a way where you don't look at us as government, you look at us as the health authority. We don't look at you as a fundee, we look at you as a health and wellness partner to the work. And so how do we do this together? So a lot of dialogue we'll have to have as we move into that phase of our relationship. But what we want to do through this session is start trying to get to a new level of dialogue. And so you see with this slide, the outer portion of the ring with the Health Directors Association. This is the area that we're trying to focus on with some of our discussions with the Health Directors Association. Here's where we understand that we work with the collective and representative voice for First Nations health directors. So we're trying to understand how to do that and to get the kind of strategic level advice in response to a strategic level question to address provincial-wide issues. So this is what we've got to figure out together. This is how we talk between the Health Authority and the Health Directors Association, trying to differentiate between the conversations that we'll have with you at a regional or even at a local level within the scope of the area of decision-making and full responsibility that you have on the ground. So it's a different kind of conversation that we're trying to get to. And I think it's important that we are able to establish this, because this will provide the advice that the Health Authority needs to develop some of its approaches that are trying to be the best approaches for the entire First Nations population in the province. not so much just for one community, but for the population as a whole. A lot of the discussion we've had in the past and the lessons that we've learned from Alaska is that it does take time to get there, but you can. Alaska talked to us a lot about how their ability to come together to make decisions for the greater good of all are good decisions to be made, but sometimes challenging because not everyone can always get everything that they want. So that's what's going to be in front of us. And so we want to try and develop that level of dialogue and to differentiate it from those other levels where we have to talk, you know, at a different level about different matters and their role changes. Because when we move into the area of health services on the ground within the mandated organizations that you all run, that's your decision-making space, not ours. And so what we're trying to do is find a way of differentiating the conversation. So this is one way of thinking about it. When you look at the operations on the ground, health directors running community programs is a lot bigger. Going to the dialogue at a regional sub-caucus level and meetings, it becomes more of a collaborative discussion on what's going to happen in a region and how things might be done. There may be different levels of shared decisions that are taken by communities or by health directors together to work in bigger collaborations or to address issues collectively. And then we look at the strategic level advice on provincial-wide strategies of the association as a whole. And so I'm just trying to find ways to see if we can clarify what this is in terms of the new level of dialogue that will help guide our work in providing the provincial-wide strategies to work towards improving health services. So we're going to look at the engagement pathway that was provided through the work that the council did with communities. And so we're understanding that this is the pathway that we're all intending to use as we move the work forward. So what we'd like to do is to be able to look at each of those 5 areas and describe them in a way that supports this new level of dialogue that we're talking about. So engagement, so processes to collect, really in my mind, the raw data. The general discussion on a subject matter, if we give you a strategic level question, we hear from everyone on their perspectives on it. From that, we have to be able to look at some kind of way of rolling all that up into a discussion document and an engagement summary, which talks about, here's the scope of what everyone talked about, here are the things that we think become the common voice in it all. And that common voice then can confirm what some of the priorities might be from a provincial-wide strategy perspective. So we want to make sure that we have the opportunity to feed that back to you and that we get an understanding, a consensus, if you will, from health directors that is your strategic level advice that's been built from all the raw data, if you will, the various pieces of information that health directors provided us collectively. And then to ensure that health directors are able to endorse that in terms of the notion of a ratification piece, but just an endorsement of it at a high level, that this makes sense to you, this is the advice you want to give the health authority that we'll take into account in the work that we need to do. And then our ongoing relationship will talk about how that advice has been implemented and how the strategy or the approach that we're trying to move ahead in partnership with all of our partners is actually progressing. So just a quick piece on some of the potential engagement opportunities for strategic level advice. So there's a number of things we can do. One is like at the Health Directors Association AGM, like we're here now, and we'll try and take that opportunity tomorrow to try some of this out, to see how we can work at gathering the strategic level or gathering the input to get to strategic level advice. And so we'll have some areas that we'll look at that tomorrow. We know that through regional caucuses, which happen out in the regions or even at a sub-regional level, there may be the opportunity where the health directors might be holding a health director specific part of the conversation. So there may be opportunities for us to piggyback on those. So we know that every region's going to do it at one go around of caucuses, then we can put a question to each of the regions. We need to make sure that each region though has the same question and provides its input so we can roll it up. That's going to be important for us. Gathering wisdom every 18 months is an opportunity again. If we align it with a Health Directors Day, or we will have a discussion on health services and initiatives, then there's an opportunity to do that. We also know, though, that within both the regional caucuses and the gathering wisdom work, there's always political work as well that has to happen. But we want to make sure that we have a specific conversation with health directors on a strategic level question that's for the health directors only. Like, we need to make sure that happens, and that those other conversations that happen for the political folks, sometimes health directors are part of that depending on the question, sometimes they're not depending on the question. So we want to make sure that we have with health directors a very specific engagement pathway, if you will, that you guys can expect and understand on a regular basis. The other way is to do it virtually. So we've done it before with surveys and email. We've done UBC learning circles, which we get a fairly good response to in terms of participation. Those all present opportunities too. So depending on the question, there's opportunities to do it in several different ways. But we should be putting out, you know, maybe 2 or 3 or 4 strategic level questions a year and trying to develop these concepts and these different approaches. So that's something that we need to start working towards on our side. And we'll work closely with your executive director and your team to make sure that we get this moving. So getting started, what I wanted to just share with you is just what I am anticipating will happen tomorrow on day 2. And so we have 5 areas to look at. One is going to be this tool, primary care tool. We might give it a better name too, I think. I don't know if it's just that, but really what it is, it's a way of looking at, we want to create a way of looking at health and wellness needs in communities. And this will be something that will support health and wellness planning in the future, but also discussions with partners on, you know, what does a comprehensive suite of services look like in terms of what First Nations would require in community and where do they come from. So we'll talk a bit more about that. Community health and wellness plans, so some discussion on that. I know there's a lot of anxiousness to get busy on this work and move it forward, so we'll have a discussion on that tomorrow. FNHB, as I mentioned, looking at a provincial approach on trying to identify, you know, what the issues are. So we've gathered information before in the past from gathering wisdom discussions and other things like that. That information will be brought back to you tomorrow and shared with you, and trying to reconfirm, you know, is it all there? Are there other things? What are the priorities that we should be working on? Health actions, there will be a discussion on a provincial approach to traditional wellness and health service integration. And a discussion on the Health Authority website build. So an opportunity for you to give feedback on the website that the Health Authority will be launching sometime in the new year as the First Nations Health Authority. So the discussion will give you an opportunity to help ensure it meets your needs and it makes sense in the way that it looks, so that it's easily navigable. So in each of these areas, we'll have presentations. Each of them will use probably different approaches in terms of World Cafe and other kinds of things to gather information. You'll have an opportunity to participate in all 5 discussions, so everyone will have input and build on what's been done. And then we've got to, as I mentioned, ensure that we effectively roll up all that information and provide it back to you to ensure it is what you've said, and that it can represent a strategic level advice from the Health Directors Association as a whole. So that'll be the goal of tomorrow afternoon's activities, and I'm really excited to see that we're going to get started on this and try and figure out the best way to accomplish what we need to do at that level. And by all means, you know, your input and feedback, not only into the questions but into the process, is going to be important so that we can refine it moving forward. The last piece I wanted to talk to you about was just this tool that I mentioned, this primary care tool. Now, some of you would have seen this. It was Mara Andrews, who is now doing some consulting work with Vancouver Coastal Health, had been developed a bit of a tool or a model that she talked with some of you about in the Vancouver coastal area, and I think she talked to Virginia about it as well, as a way of looking at, you know, the suite of services in communities and how it connected into, you know, what's in communities at the center that really belong to us around our spiritual, traditional, and cultural pieces, the teachings and practices, and then the kinds of things, the programs and services that are needed in communities, which really are part of our primary care spectrum in one way of looking at them. And then the secondary care is, you know, the goal that we have is to not be in the sickness system any more than we need to be, but the secondary care is really what's provided by the province. Now, she got some good initial feedback on this as a concept, and what I was hoping to do in the discussion tomorrow is to have more folks have a chance to look at it and give their input into it, because we just want to have a tool that kind of gives us a sense of how we might want to talk about the whole suite of services and care that's needed from a health and wellness perspective. I think what's important in it, when I was looking at the model, and the one you'll look at tomorrow, in each of these areas we'll probably list more of the programs, specific programs and services that are available. And what was interesting was that when you see that there are a lot of services in the middle circle or the inner circle, the primary care, where the blue circles are, that are actually provided by the province that should be available in community. And that's one of the commitments that we have and we're reinforcing in this health plan, is that provincial services are available for First Nations people regardless of where they live. So the interesting part is that we see some of those services that the province should be making available in community. We see that we're actually providing them through our own mandated health organizations, where we don't have to be. We can be using that money for other things that the province doesn't provide. So it creates an interesting way of talking about these things, and that's just one example. Now, you can look at this kind of a model and say, okay, for one community, could you put all this in place? Maybe, maybe not, depending on the community, its location and size. But for a number of communities working together, could we achieve this so everyone has access to this, if right now they only have one area or another? Like, it provides a useful tool to help stimulate a number of different conversations moving forward. So we just want to be able to have that conversation. And I really thank Mara for her work in putting this together. It was a great start to something, and with our partnership with Vancouver Coastal Health, with them allowing us to leverage some of her support so that we could bring this here and elevate it, if it is the right tool, to something we can use in each of our regions. And there's a lot of other work that needs to flow from that, because after this you need to map the services and look at where they come from and what they look like, and where should they be coming from, or who's working with who or who's not working with who. And I think the important part in my mind, this is the FNI+++. This is what makes it work for us as First Nations people, to have a say in all of this, and not just, but also to address this work from the center, where the spiritual, traditional, and cultural component with the human being in the center is really essential to how all of this should happen. So it becomes a very interesting tool for us, and I'm really excited about having the opportunity to talk about it. So I'm actually going to finish early. Is that okay? Yeah? All right. Thank you very much. That's all I got for today.